Welcome to Pediatric Grand Rounds. This is in concert with tomorrow's Nadav Robinson Grand Rounds, which has become an annual event, and I would encourage everybody to come tomorrow to Grand Rounds at 8 o'clock. And the reason which you should be encouraged is we have a wonderful guest today, Dr. Stephanie Ware. Dr. Ware is the chair and professor of the Department of Medical and Molecular Genetics at Indiana University. She's also professor of pediatrics at Indiana University and director of cardiovascular genetics, their Center for Pediatric Research at Indiana University as well. She directs the Indiana University Health participation in the NORD Rare Disease Centers of Excellence Network, and she co-directed the Genomic Medicine pillar of the Precision Health Initiative. And she leads the Diagnostic Center of Excellence site of the NIH Undiagnosed Diseases Network. She also directs a basic and translational NIH-funded research lab. Hopefully it will be funded soon again, investigating the genetic and developmental basis of congenital heart defects and cardiomyopathy. And she's a member of the American Society of Clinical Investigation. It is really a wonderful honor to have you join us today. We're so excited that you're here to speak with us about genetic evaluation in pediatric cardiomyopathy, which we all know is a very big interest of yours. So thank you so much.
Thank you so much for that introduction, and it's really great to be here. I appreciate the invitation. And so I was asked to maybe talk about cardiomyopathy today, since I'm talking about congenital heart defects and heterotaxy tomorrow. And of course, as a geneticist, I'm going to talk about the genetic evaluation of cardiomyopathy, but it was a little bit challenging to think about what would be of most interest for this audience, because I know you have great expertise in genetics here. You have cardiovascular genetics, and then a couple of you I know from the Pediatric Cardiomyopathy Registry. And so a little bit more difficult to know, what's going to be of interest. But I thought I would start by just giving a little bit of an overview about some of the key challenges, I think, from a genetic standpoint in pediatric cardiomyopathy, and then show a little bit about what we've done at our site. I've just been at Indiana University for 10 years now, and I was recruited there to develop a cardiovascular genetics program. And so talk a little bit, we've kind of looked back at our 10-year retrospective history, what kind of single site cardiomyopathy looks like. Then I'm going to present some of our work from the Pediatric Cardiomyopathy Registry. And I'm happy to take questions throughout. If I have time, I'll talk a little bit about some more basic translational research we're doing, looking at genomic and transcriptomic investigation of restrictive cardiomyopathy, which is a real interest of mine. But if we don't have time and don't get to that, that's fine too. So as you all know, I think I will, if you guys can still hear me, because it'll be easier to move this. So obviously cardiomyopathies in children are heritable, and the phenotypes that you see here. But one of the challenges is that there's so many different genes that underlie the different causes of cardiomyopathy. And even in families where we know that there's a clear autosomal dominant history, we don't always find the causative gene. And what you can see here is the pathways overlap. So the same gene can cause dilated cardiomyopathy as causes hypertrophic cardiomyopathy. So I think we have a lot to learn still about how a single gene can cause these very different phenotypes. In addition, in the pediatric realm, of course, we have the additional challenge of having a lot of metabolic disease or genetic syndromes that can present with cardiomyopathy as well. And while we know the sort of the board exam presentations for these, the reality is that most patients don't present like the classic picture, the board exam picture. And so I think with the increasing tools that we've had from a genetic diagnostic standpoint, we're really continuing to enlarge the spectrum of what we understand pediatric cardiomyopathy to be. From a geneticist, it's an area that's really sort of satisfying to see patients in, because compared to many other areas of genetics, we actually do have a fairly high diagnostic yield, and we're able to identify the underlying cause in a larger percentage than what we do for some other disorders. And I think part of the reason for that is that it makes so much biological sense in terms of what the potential culprits and underlying causes may be. And so you see here, different components of the sarcomere. Obviously, the first genes that were identified as causing hypertrophic cardiomyopathy as being a disease of the sarcomere are all of these that you see down here, the thick filament, MYH7, beta myosin heavy chain, and then the thin filament genes, the different cardiac troponins, and then myosin binding protein C3, which connects and interlaces between thin filament and thick filament. You've got the cytoskeleton, which is so important for being able to mitigate the conductive forces that are occurring during contraction and relaxation. And variants in those genes can cause dilated cardiomyopathy, but also underlie some of the more neuromuscular disorders. And then obviously for arrhythmogenic ventricular cardiomyopathy, often known as kind of a disease of the desmosome. So this gives us, sort of great biological substrate in terms of identifying new causes of cardiomyopathy, or maybe better understanding some of the mitigating factors or modifying genetic influences that may play a role in the phenotypic presentation. And so, as you all know, I'm sure there's a number of uses for genetic testing, and really, what I'm going to talk about first is just the use of genetic testing to confirm a diagnosis, to rule in or rule out a syndromic cause of cardiomyopathy, and then risk predictive testing for family members. So here again, we see the different phenotypes of cardiomyopathy that can occur, with kind of the predominant underlying genetic cause highlighted with each of those. But the reality is that clinically, the percent yield that we have in terms of diagnosing the different phenotypes is variable. So, we're kind of best with hypertrophic cardiomyopathy. The 80% for arrhythmogenic ventricular cardiomyopathy, I think, depends on how you're defining. If it's really your kind of pathognomonic imaging ABC case, then yes, probably as high as 80%. If it's a more equivocal, unclear diagnosis, the percentage is going to be much lower than that. And then for dilated cardiomyopathy, I think 30% is probably our most optimistic yield right now. That's if there's a clear family history of it, then yes, I think 30% is accurate. But for only affected individual in the family, especially if it's an infant, it's going to be quite a bit lower than that. So, I mean, that kind of shows you the way that we have to go still to get to the ceiling in terms of our being able to make the diagnosis. And then the other thing, just from a genetic standpoint, is that although cardiomyopathy is a diagnosis, of course, it's also a phenotype. It's not a diagnosis in terms of what the underlying cause is. And so this, a decade ago, this was sort of a soapbox for me as a geneticist, because especially the adult cardiologists were very fond of saying, well, no, HCM is a diagnosis of the sarcomere. If it's not an MYH7 or MYBPC3, that's not hypertrophic cardiomyopathy. And so you had to sort of play these games with Noonan cardiomyopathy or whatever. Like it wasn't really HCM, it was Noonan cardiomyopathy. But, for me as a geneticist, what I always say is, this is what you see when you're looking at the patient. I mean, they don't come into the clinic and tell you, oh, I have Noonan syndrome, or oh, I have sarcomeric cause of my cardiomyopathy. And while again, there are definitely patients that are textbook cases of Noonan syndrome. Pretty much every year, I either diagnose a parent after I diagnose the child with Noonan syndrome, and the parent, their whole life has gone undetected, or I diagnose an adolescent who's been followed for hypertrophic cardiomyopathy since they were 3, and just nobody thought about it because they don't really look that much like they have a genetic syndrome unless you have a high level of suspicion. And I think the same goes for dilated cardiomyopathy, and maybe even more so because I think the syndromic causes of dilated cardiomyopathy are often more esoteric, especially, you know, when you get into mitochondrial disorders or inborn errors of metabolism. Those presentations don't necessarily come with short stature or dysmorphic features. They come with heart failure as a primary symptom. So I think, you know, from this standpoint, being able to understand the underlying diagnosis is very important, and it's going to become increasingly important as more and more therapies, you know, now that we know that, you know, treatment for severe hypertrophy with Noonan syndrome, that you know, you may want to be using MEK inhibitors for that, or different medical therapeutic. And as gene therapy starts to come online, knowing what the underlying cause is or is not is going to become a very essential element to being able to decide what the treatment course is going to be.
The sorry,
Yep.
the yield, the percentages that you had, they were all for pathogenic and likely pathogenic, I assume.
Yeah.
Okay. We do see sometimes like all these VUSs, and then you don't know
Right,
whether
yeah.
they're the disease causing variant or not.
And of course, that's the challenging thing, you know, the variance of uncertain significance. And I have a slide on that next. But, you know, even I think if a molecular diagnosis is not made, being able to put a patient into the categories that were established by the Pediatric Cardiomyopathy Registry, you know, sort of in the early 2000s, in terms of, is this familial because you can see an inheritance pattern? Is it a metabolic or syndromic cause that the patient has multiple other medical problems, and it looks like there may be a unifying diagnosis there, even if we don't make a diagnosis on a molecular basis. And then obviously neuromuscular, typically, you know, those will be detected, you know, from the skeletal muscle standpoint, often before the cardiac involvement, or they're not such a, you know, clinical diagnostics challenge. But there still are individuals with, for example, the limb girdle muscular dystrophies or sarcoglycanopathies that we will see sometimes come to pediatric clinics that have cardiac manifestation as sort of their first presentation. So there are a number of helpful guidelines, especially for the trainees in the audience. Important to know that, you know, AHA and the Heart Failure Society of America, as well as our genetics kind of guideline groups, ACMG, have put out specific guidelines related to pediatric cardiomyopathy and genetic testing. And so the only slide I really have about, you know, variants and variant classification is just this, which is a reminder that the stringency of clinical classification has been raised over the years. So in 2015, new guidelines came out that sort of elaborated this benign, likely benign, variant of uncertain significance, likely pathogenic, and pathogenic grading scale, if you will. And really, to be called benign or pathogenic, you're at the like upper 1% or lower 1%. So what it really did was widen that VUS basket, and it increased the number of elements required in order to be able to upgrade or downgrade a variant. And that's probably overall a good thing, because too often variants were being labeled as disease causing without due diligence, and, you know, primarily based on bioinformatic characteristics. So I think overall this has been good for the field, but the challenge is that some VUSs are very suspicious VUS. Others are not at all suspicious.
Oh, Indiana?
And so it's something that then you have to constantly revisit with the patient. I think the other issue with this is that this is sort of the grading scale for all variants, regardless of the clinical area. And so we know that in cardiomyopathy or cardiovascular genetics in general, the inheritance pattern and the expectation of how many are something that's occurring for the first time in the child versus something that's inherited is going to be very different than in your general medical genetics clinic. And that inheritance pattern plays a great deal into the determination of this. And so at the end of the day, this is a sort of a laboratory classification, and ultimately it's the physician that makes the diagnosis in the child, the physician that understands the clinical context. There are times where we're quite certain that a VUS is the cause of disease in the patient, and we will upgrade that and treat the patient that this is the cause of their disease, and yet the laboratory doesn't yet have enough evidence to like change that in their kind of laboratory setting. And Bruce has participated on many of the ClinGen panels that really have experts in the field to curate these at an even higher level, which I think is important when because there are really just disease-specific nuances that need to be taken into account. So let me talk a little bit then about what we've done at our institution and my interest in really trying to better understand how we're implementing genetic testing, and the idea that, these guidelines, some of them were made 15 years ago, and they're still not fully in play in every institution around the country. And what I learned was that even if you have a discovery of a new gene that may cause, a significant percentage of disease, that's not going to be implemented quickly. There are certain barriers to that. So trying to better understand, although I'm not a health implementation scientist, trying to better understand what some of the barriers are. And I think some of the barriers are that we tend to not publish very good data with regard to this field. And so at our institution, as I said, when I came to IU 10 years ago, I was recruited to develop cardiovascular genetic program, both clinical and research. And so we started really on the pediatric side and established multidisciplinary clinics from the get-go. So we have a multidisciplinary cardiomyopathy clinic with heart failure transplant cardiologist. JJ Parent is the first one and has been the main one there. Now Megan Wild and Sabina Hussein, the three of them run the heart failure transplant program. So we have 3 times a month clinics with a geneticist and them, and then basically every week a genetic counselor in them. So the geneticists don't see all of the cases, but we see any child under the age of 5 and anyone triaged from the genetic counselor, anyone that has kind of a more complex presentation. We have the same clinics for aortopathy, and then genetic counselors that staff clinics with the EPs, the preventive cardiologists for lipid clinics, and pulmonary hypertension. And so we've had a clinical registry. We have about 7,500 patients over the 10 years in that clinical registry. And so we wanted to just look back at, from a cardiomyopathy standpoint, who are the patients that are coming to this clinic? Let's, take a snapshot of what that looks like. And so over the last 10 years, we've had 1,515 pediatric patients that were referred for a personal or family history of cardiomyopathy. So they're coming in from a lot of different ways, just as you see how they got diagnosed with cardiomyopathy, if they themselves have cardiomyopathy. Sometimes they're, coming in acutely and getting hospitalized. Other times it's diagnosed incidentally on a chest x-ray or something like that. Same thing with regard to referral because of family history. Sometimes that's a very good family history. Family member has already had genetic testing. Other times the family history is, well, it seemed like there was a lot going on and the grandfather just died. So, you get quite variable referrals to this type of clinic. And so of those 1,515, actually 499 of them have cardiomyopathy. And of the 499 with cardiomyopathy, 36% or 178 had a pathogenic or likely pathogenic variant on testing. This is first line here. And then 26% had a variant of uncertain significance. 22% were negative, and then 16% had either had testing that was still in progress at the time of the data collection, or had not had any genetic testing. So, I mean, that was a very interesting number for me, you know, from a QI standpoint. 16% seems like we should be able to do better than that. And we're trying to dig into that 79, like how many, like what are the barriers there that the testing's not getting done? Then for the little bit over 1,000 that do not have cardiomyopathy, 29% of them have a pathogenic or likely pathogenic variant. So these are your genotype positive, phenotype negative individuals. They've come in because they have a family history. They get, you know, usually we've tested the affected family member, and we know what the, you know, we have directed testing every once in a while. We will test someone, especially if there's a very clear dominant history in the family, but we can't get testing on the affected individual. These are very rare cases, but occasionally we will do that testing. As you would expect, a much lower VUS rate in this population, only 3%. 17% that are negative. So these are the individuals who have probably an affected parent. They've got a 50-50 chance. They're either going to have the variant or they're not going to have the variant, and they don't have the variant. And then fully 50% that get no genetic testing. And these are the individuals who it's just not indicated to do testing because they're not affected. We don't have a family member to test. Having a negative test in them is not going to be informative.
Thanks for the question. So you're positive in the negative column that you're talking about right now. Those with the variant, it's 29%. Those that are negative are 17%. Why aren't those two percentages roughly equal, since these are all dominant and these are all phenotype negative?
Yeah, I mean, you would think they should be more 50-50. I don't have a clear answer for that. You know, some of those are going to be syndromic cases where it could be de novo, but they don't have cardiomyopathy yet, but they do have a pathogenic or likely pathogenic variant. Probably not going to be enough to make up that 12%. We've got, and I'm going to show it. I mean, we do have, we've got probably 70 or 80 patients that are going to be syndromic. So, you know, you're getting a little bit closer to the number. It is probably going to be 8 or 9%, but so it may be within the, you know, statistically not different at that point once you add in the syndromics. But yeah, that's a good question.
Family history, like, do you only consider like first degree relatives when you think of like family, like, you know, positive family history for cardiomyopathy?
So this would be if they get referred to us and we see them, they go into this clinical registry. So if they get referred for a family history of cardiomyopathy, and as it turns out, it was a second cousin who had sudden death or whatever, they're still in this registry. They didn't get, if they had a normal echo, they didn't get tested. So they would be, you know, here in this negative, no genetic testing. And, you know, those are going to be ones that are going to be discharged from clinic and kind of seen once type of thing. So like I said, I think it's sort of interesting to look at the data this way because it gives you an idea of, we see so much variety in these clinics, and they're very, you know, a patient like that is very different than the one who's coming in with the dominant family history, right? Where you've got 5 affected family members. And that's where I think, you know, just reporting numbers out and diagnostic yield can be very misleading. And it's not the best test of how well are we doing in terms of taking care of these patients from a genetic standpoint. So this is just some of the demographics of the 499 patients who have cardiomyopathy. It's a lot of numbers. The 2 take-home messages, I think, are that in general, with the exception of dilated cardiomyopathy, where we have a 54% to 44% female to male ratio, for any other cardiomyopathy phenotype, more males than females, very small numbers for some of these categories, but certainly for hypertrophic cardiomyopathy, 61% to 38%. And then just from a race ethnicity standpoint, Indiana is not the most diverse population. So I think the numbers that we see here very much represent our geographic distribution. And we'll see when I get to the pediatric cardiomyopathy registry studies that that there's some interesting race and ancestry numbers to go along with these phenotypes. So this is kind of distribution of all of the pathogenic, likely pathogenic variants within our population. Again, because I'm going to show you PCMR data after this, very interesting to me that 152 MYBPC3 pathogenic, likely pathogenic variants, which far outnumbers the number of MYH7, which would not have been necessarily what I expected. And then just anecdotally from seeing patients in clinic, and then Titan is the third most common, and then there's PTPN11 right at number 4. So
do you have a lot of unique MYBPC3 variants, or are there like founder variants that are representing a large burden of that?
Not very many founder, yeah. We have, we do have a big Amish population in Indiana, but very few. There actually is a very nice clinic for cardiomyopathy for the Amish patients. So we see almost none of those patients, but there's a, MYBPC3 founder variant. So this is kind of another way of looking at the prevalence of the variants. Very complicated slide. What you're looking at is every row is a patient. So each little kind of hash mark is a patient. And then going down, every column is a patient, and then every row is a different gene. So across the top here, each one of these little marks is a different patient who has a variant in MYBPC3. And then, so if we'll just look at MYBPC3 as an example, so of all of the MYBPC3 variants, almost 29% of them had hypertrophic cardiomyopathy, 4% of them had dilated cardiomyopathy, 0.5% restrictive cardiomyopathy, and then 58.2% had no cardiomyopathy yet. So this again is your genotype positive, phenotype negative pediatric patient. And so and then this also includes our variants of uncertain significance. And so we kind of just wanted to look at, well, what's our ratio of our likely pathogenic variants versus our variants of uncertain significance, and is this meaningful at all? So the ratio for that is 6.61. I don't really know what that means, but if we then look at PTPN11, where, sort of reassuringly, almost 22% of them had hypertrophic cardiomyopathy. None of them have any other kind of cardiomyopathy. Almost 70% have no cardiomyopathy yet. And then, you look at your pathogenic, likely pathogenic versus VUS, and that ratio is 22. So that's kind of what we would expect, right? We don't get that many variants of uncertain significance that are causing Noonan syndrome. It's, I think the databases are better curated. We have better evidence for the variants that are present there. So it's easier to make that pathogenic, likely pathogenic, or benign, likely benign call for those. Then if you go and you look at something like SCN5A, which is, a gene that no geneticist likes because there are too many different phenotypes that probably acts as a modifier for many phenotypes. We have 3.7% associated with hypertrophic cardiomyopathy, 41% with dilated cardiomyopathy, 18% no cardiomyopathy. But you look at the pathogenic, likely pathogenic to VUS, 3 to 19, and you see the reason that no geneticist likes this gene, because you get these VUSs and you have it, you've done the testing for a reason. The patient has a phenotype. Now, is this gene related to that phenotype or not? It's going to be much harder to say. So I think, this may be a little bit helpful in terms of, thinking about the tolerance for variants within a gene. And this is, some of the work that ClinGen does as well.
How many of the patients have 2 or more PO variants?
Have
2 or more hits?
Yeah, I'm going to show
Okay.
that. I'm going to show it not for our patient population, but for the Pediatric Cardiomyopathy Registry. This just looks, this is for geneticists. It looks at the type of variant it is, and kind of as we expect across all like phenotypes of cardiomyopathy, most of them are missense variants, but we do see, insertion deletion, we see splice site variants, we see nonsense variants. I think that this is important kind of longer term, besides academic interest for geneticists, because the types of therapies when you're talking about trying to, alter the protein or to block the abnormal protein that's formed, the therapy that's going to be directed to that is going to depend on, is this loss of function, is this gain of function, dominant, negative, what's the mechanism of what's happening at the protein level. So you kind of need to know what the gene variant is to begin to get at that. And then if we look at the different syndromes that are seen, the take-home message here, a lot of different syndromes, most of them seen only once. And I mean, that's what we know in genetics. We see a lot of rare disease. So it's not surprising that we have a lot of kind of one-off diagnoses in these patients. And I think that's what makes it so challenging to have a high level of suspicion that something syndromic or metabolic is going on, is that it's very likely that it's something that you've never seen before and you may not see again for the rest of your career. So how do you train people to recognize that? But we do, of course, have more patients with rashopathies or Noonan syndrome. So we kind of were just curious, again, just looking at our data. One of the things that I think you can do well as a single site is if you follow these patients longitudinally for a long time, you're able to collect sort of natural history data on them. And so we haven't really done much of that yet, but what you see here is we do have a nice representation of the different genes that cause Noonan syndrome and other rashopathies, Costello syndrome and CFC. And then we were kind of curious is, can we begin to try to look at the penetrance of cardiomyopathy in these patients? And of course, penetrance is going to depend upon the age at which you see them, right? So the hope would be, we'll follow, sorry, this is skewed, but you'll follow these patients till adulthood and then you'll know. But, for example, Costello syndrome, we have 4 patients with hypertrophic cardiomyopathy, 1 who has not yet manifest, but that 1 who's not yet manifest is already 24 years old. So may or may not develop, as opposed to our NF Noonan syndrome, our 1 patient that doesn't have cardiomyopathy yet, it's only 2 years old. So still a long way to go there. But, this is sort of beginning at getting at some genotype, phenotype correlations there. So next, then I want to go on this, sort of a single site snapshot. With the Pediatric Cardiomyopathy Registry, we were really looking at things on a research basis. So all I just showed you was done on a clinical basis. With Pediatric Cardiomyopathy Registry, we started this study 10 years ago, actually, of collecting all pediatric patients with cardiomyopathy that was not recognized as being syndromic, metabolic, or due to some other cause. We did, after a couple of years of the study, allow patients with myocarditis to be enrolled in the study. So we have a fewer number of those patients. But basically, it was a longitudinal cohort study. We did exclude ABC cases just because we didn't think there were going to be enough of them that could be collected that we would be able to say much meaningful about them. And whenever possible, we collected parent samples as well. And then we did exome sequencing on all of those patients. And to begin with, we just focused on 37 genes. At that point in time, panels were relatively small. And then, over the course of the studies, the panels got, very much bigger, but we kind of stuck with those 37 to begin with and then have expanded out. So I'm going to show you the initial results of 37 and then what we've done to try to take a broader look at more candidate genes, beyond what's on current panels. So when we first started collection, when we got about our first 150 patients, we said, well, this gives us an opportunity to really look at what clinical testing is being done at places because, you know, they're enrolled to this research study. Some of them, if they have had clinical genetic testing, we would receive the copies of that testing. And, you know, the first 9 sites that contributed, a couple of them had very small numbers, but you can see everything from below 20% that were having clinical testing to almost 100% that were having clinical testing. So that kind of gives you an idea of, at least at that point in time, which was like 2016, 2017, these are, you know, all places that have well-known heart failure transplant programs that got experts in pediatric cardiomyopathy, and that's the range of testing that's being done. So you know that your less academic centers with less expertise are probably doing the low end of this or less. So it seems like a really good opportunity to be able to make a better impact. And then, you know, the other thing that was nice, because we were doing exome on all of these, we had the opportunity to say for these first 152, we knew, you know, on average, when we took all of them, all of those sites, 53% had had prior testing. And so, you know, if all of those patients, if 100% had had clinical testing, how many would have gotten a clinical diagnosis? So we interpreted our findings in these 37 genes per ACMG standards. And what we found was an additional 21% would have had positive results. And that obviously has important implications for being able to screen family members, if there are siblings that are at risk and so forth. And the other thing is that when you just look at the number of patients that had had the clinical testing, so HCM was the best, where 50% had had clinical testing. DCM, not surprisingly, was the worst, with only 14% that had had clinical testing. So again, gives us a good idea of where we have an opportunity to make an impact. And then the phenotype distribution for this, about half of the patients had dilated cardiomyopathy, 30% hypertrophic cardiomyopathy, and then smaller percentages of the other phenotypes. And here's where we see some interesting demographics. So again, here we see a male preponderance in patients with hypertrophic cardiomyopathy, more so than any other phenotype. And then if you look at ancestry, 80% of restrictive cardiomyopathy patients have European background. Small numbers, 30 patients, but I think that this is pretty reliable. 71% with hypertrophic cardiomyopathy. On the other hand, dilated cardiomyopathy, much more common in those of African ancestry and admixed ancestry, which would, the biggest component of that admixed is Hispanic. And then the other thing you see is that there's a very big difference in the average age of diagnosis. So for the whole cohort, 528 patients, average age of diagnosis is 3. But if you look, you know, dilated versus hypertrophic, average age for dilated cardiomyopathy diagnosis in this cohort was 1, and for hypertrophic cardiomyopathy is 11. So, you know, looking at very different populations there. So, and then just looking at the diagnostic yield of exome sequencing, looking at just those 37 genes, were the worst for dilated cardiomyopathy, right around 20%, and were best for hypertrophic and restrictive cardiomyopathy, right around 50% for both of those. And then I think the numbers are too small to say much based on ancestry for anything other than dilated or hypertrophic cardiomyopathy, but I'll show a little bit more about this on additional slides that really were overall much better at making a genetic diagnosis in individuals that are white than individuals who are not white. And there may be multiple reasons for that. The other interesting kind of demographic that fell out of this is that we're much better at making a genetic diagnosis in individuals over 1 year of age than we are in individuals under 1 year of age. For the specific phenotypes, it didn't actually reach statistical significance, but for the overall cohort, it was highly significant. And I think the trends are very much there for DCM and HCM. So when we look at, how does really the genetic findings compare to what we know about genes in the adult population with cardiomyopathy, mostly we see shared causes. Again, remember that this cohort, if you were known to have syndromic, known or suspected to have syndromic or metabolic causes, then you were excluded from this study. So this should be enriched for patients that have more of the sarcomeric or cytoskeletal variants. And so we see MYH7 as the most common cause and MYBPC3, but interesting for restrictive cardiomyopathy, 10% had MYH7 as a cause, and we had no individuals that had MYBPC3, but 30% had a TNNI3 variant. So I think, and this has been shown in the literature before, but this is the largest numbers to have shown TNNI3 is an important cause of restrictive cardiomyopathy. And then for DCM, in adults, 6%, which is a pretty high molecular diagnosis rate for dilated cardiomyopathy. 6% of adults have lamin AC, and that's a gene that's known to have high arrhythmia burden with it. There are definitely different treatment options that are considered at the time of diagnosis if you have a LMNA genetic cause, but in the pediatric population, only 1.4%. And similarly here with Titan, 10 to 20, thought to explain 10 to 20% of adult dilated cardiomyopathy, but we're only seeing it in about 3% of pediatric patients. So it may very well be a susceptibility allele in pediatric patients, but not thought to explain a large proportion of those patients. So, that was research-based exome, but the results all interpreted according to clinically stringent standards, which isn't really feasible to do widely if you want to look at 2,000 genes or something like that. And we really wanted to expand and look at a larger number of candidate genes. So this slide is just to show kind of different the way we broke into different gene sets to analyze. So the first gene set, what we're calling our initial or curated gene set, has 37 genes in it. We looked at all genes in ClinVar that have been annotated for cardiomyopathy, and there are 70 total. Many of them are, these 37 genes. So if we combine these two sets, we get a cardiomyopathy-associated gene set of 75. And then we have a broad cardiac discovery gene set, which are genes that are important for the function of the sarcomere that are known to be highly expressed during cardiac development. And then we looked at a subset of those cardiac discovery genes to look at specifically at genes that don't tolerate variation very well, because we thought our bioinformatic prediction programs are going to work very well for those particular types of genes. And so we made what we're calling an intolerant gene set, which is just a subset of these cardiac discovery genes. So I'm going to show you some data that kind of looks at basically smallest gene set, just those 37 genes, to progressively larger gene sets. So this is, as you've seen, as I showed you before for our site, just kind of looking at the results by variant. And the one thing that I want to point out of interest on this is really looking at the variant burden based on ancestry. And very interesting here is when you look at myosin binding protein C, what you see is that it explains 4.6% of cardiomyopathy in those of European ancestry, but it explains 0% of cardiomyopathy in individuals of African ancestry. Again, anecdotally taking care of patients in clinic, I was very surprised by this. It had never registered to me that Black patients that I take care of have never had an MYBPC3 cause. And I'm sure that this is not absolute, but it's a very striking difference. And so, again, I think that focuses us on the fact that there are going to be some ancestry specific differences here in terms of which genes are important causes. And this just blown up so you can see that a little bit better. So then we wanted to look at really variant burden. And we're not necessarily saying that these genes are causative because, or that these variants are causative, because what we're using as our metric or yardstick is just a bioinformatic prediction that says, oh, this particular change has a big impact on the protein. And we know that that doesn't meet the stringent thresholds for us, in the clinic to say this is the cause in this patient. But so the way we did this was a case control study where we had two different control populations. I'm showing the control population that's just 1,000 genomes. We also used, with Wendy Chong, used the Spark autism group, and we got similar results with using both. And so the idea here is if we look at a set of genes, whether it's 37 genes or whether it's 2,000 genes, if we look at a set of genes in cases and we look at the number of variants that are predicted to be damaging in cases, if they actually have something, if those genes actually have something to do and are associated with cardiomyopathy, we should see a higher percent or a higher burden of them in the affected cases than we should if we just look for those variants in the control population. So that's all we're doing. We're looking, we do a bioinformatic prediction. It says, yes, here's 15 variants that are damaging in this population. And then we say, is that the same, higher, or lower than in our control population? And so because of that, you get an odds ratio. And so what we have here is our smallest gene set, the curated gene set, a little bit bigger, the ClinVar gene set, a little bit bigger with more genes that have never been shown to cause cardiomyopathy before, our intolerant gene set, and then finally a combined gene set. And so what you see if you look just for, and this is, I should just say, this is just for HCM and DCM. We had two small numbers for the other. So if you look at HCM and DCM together, that's, you have an odds ratio of 5-fold more likely cases versus controls. And that's really, it's really the HCM that's driving that. But again, if you look by ancestry, what you see is that the European ancestry has a much higher odds ratio than those of African ancestry or admixed ancestry. And actually, if we go on and look at this in another way of cases versus controls, you'll see that for some populations, there's not really a difference. So this is looking at controls, and this is getting at how many have 1 hits, how many have 2 hits. So these are controls who have one hit, one variant of all the ones that we're looking at. So kind of high, right? I mean, this is not a very specific way of looking at things. This is your control population, and it's saying 11% have at least one damaging variant in the genes that we're interested in. Or in African-American individuals, 26%. But still, vastly overrepresented in the hypertrophic cardiomyopathy population, where 44% versus 11%, significantly higher. If we look at dilated cardiomyopathy, what we see here in our smaller gene sets versus our bigger gene sets is that in smaller gene sets, kind of 30% across the board, regardless of race or ethnicity. But when we get to our combined gene set, a little bit better for Europeans, 38%, but now look at those of African ancestry. Now we're up to 53%. So what this tells us is that with this combined gene set, there are some genes in there that are probably actually really importantly associated specifically with African ancestry. And we need to find out what those genes are. And then finally, I just want to show here is your number of individuals that have 2 hits and that have 3 hits in the cohort. This is another way of looking at the number of hits again. So along the bottom here, the number of hits, 0 has the biggest bar, and then going from 1 to 9. So when we look at our smallest gene set, only 37 genes, in our controls, what we see, and I should say that this was 1,000 iterations done with kind of random gene sets. 98% of the time, there were no damaging variants in those 37 genes that we know cause cardiomyopathy. But in our European population, 60% of the time there were no damaging variants. 34% of the time there was. This kind of goes along with what I've shown you already, which is that about a third of the time we make a molecular diagnosis. Sorry. When we now broaden out to get to our this was 37 genes. So now when we go to our cardiac discovery, which is almost 2,000 genes, what we see is actually really interesting, which is in our controls, not surprisingly, now we have some that have 1 hit, 2 hit, or 3 hits, but you don't have any that have 5 variants, 6 variants, 7 damaging variants. And that's very different than our cases where we really have almost like a bell-shaped curve to these. So we have, on average, 2% of individuals that have 7 predicted damaging variants. So if any of you are used to ordering clinical testing and are very frustrated when you get like 4 VUSs, I mean, I think that's what we're starting to see here. And to me, this begins to get at oligogenic inheritance. We know pediatric cardiomyopathy in many cases is a dominant disease, and you've got a clear pathogenic variant that's running through every generation of the family. But we also know, especially in hypertrophic cardiomyopathy, and this has been shown in adults, that there is some percentage that doesn't appear to have a single gene that's causing their disease, but they may have inherited 3 or 4 genes that are contributing a susceptibility that, if you have 4, that tips you over the threshold to developing it. And so the fact to me that we're seeing a bell-shaped curve here, but we don't see that in an unaffected control population, says that we need to begin to try to tease out what are the combinations of genes that may be working together to demonstrate the phenotype.
And do these have VUSs as well, or this is just?
So these have not been classified clinically. So these are all just based on the bioinformatics. So the vast majority of these would be designated a VUS. Yep.
And can you tell if the multiple hits are in cis or trans?
What's that?
Can you tell if they're in cis or trans, the multiple hits?
We can't tell. Yep. That's a great question. So, and I think, I'm almost at the end of this, and I'm not going to go on. I said, if we got through, I present the transcriptomic analysis of cardiomyopathy, but these I think are the more interesting from a clinical standpoint. So I'll just kind of finish the next few slides here and wrap up. The kind of the take-home message of this exome study is that in our total cohort, 32% had basically a clinical single gene diagnosis. We have another 33% that some proportion of that probably have a single gene diagnosis. Some of them, we clearly have identified susceptibility alleles, but it's not going to reach clinical stringency. And then we still have 35% that are really unexplained. So I think we still have quite a ways to go in gene discovery. And this is, again, just showing that that 33% is really based on an informatic prediction more than anything else. And so I think there's a lot of work to then pair the informatics back with the phenotypes and longitudinal phenotypes. And I think that's where single site studies can be really helpful in terms of really having really great phenotyping and following these patients over their childhood. So with that, I just wanted to, from the PCMR, these are the individuals, and then all of our different PCMR centers. And I will stop there and take any questions you guys might have.
The data that you showed that, the MYBPC3, it didn't explain anything in the African ancestry. Do you think there could be a component of like selection bias, like because maybe not a lot of African families decided to enroll in the study. Because it was a research study where you had to get genetic testing done, consent was involved.
Well, I mean, we definitely had, you know, we definitely had many more Caucasians than African American enrolled in this study, but we had a high enough percent of patients, even within the HCM. So I don't think we had a high enough that we could say, oh, that, you know, that number is clearly 0%. But I think our numbers were large enough that we can say it is not going to be on par with what the, you know, white European background is going to see MYBPC3. There are, though, I mean, there has been, for example, in Southeast Asia and India, there is an MYBPC3 specific variant and haplotype that contributes to cardiomyopathy. So I think there are going to be some ancestry specific variants or alleles that will play a role. And one of the values of identifying some of those things, like similar to the Amish population, is then because it's the same variant in that population, you do have a much better idea of, you know, which variants are going to be associated with bad prognosis, which ones have a high burden of arrhythmia associated with them. And I think those types of things are helpful. So we are starting to get some of those, as I said, kind of variant, not really genes, but variant and phenotype correlations. So the with the arrhythmic genes, the lamin C, filamin C, we know that those are going to be ones that are potentially problematic. And then on the adult side, that they have shown some specific variants more highly associated with sudden cardiac death or likelihood to have ventricular fibrillation.
And the BUSs get reclassified like all the time. Like, so I know there was this conversation in one of the meetings with PCMR where like, when you do cascade testing and you find BUS and they're phenotype negative, do you discharge them from the clinic? Like, do you never see them back again? How long, or should you keep them in your like pool and you bring them back after X amount of years and, you know, and reevaluate whether that BUS now is, let's say, pathogenic or likely pathogenic, and you may need to do surveillance on that patient. Like, how often do you think we should go back to those VUSs and recheck?
Yeah, I think the rechecking VUSs, and then when do you retest? Like if the patient's been tested and their testing's negative, but they have cardiomyopathy, when should you retest? I think for when they have a VUS, we usually update those whenever they, you know, if they're coming back to clinic to see the cardiologist, say every 6 months, we typically from the genetic side will see them every year, at least every 2 years, if not. And every time they come back to clinic, whether it's a geneticist or a genetic counselor, we do our own validation of the VUS, and we'll call the testing lab too, but we often will, you know, do it ourselves. So, and then we document that in the chart, you know, as of whatever date, it's still a VUS or whatever. So I think the main reason for doing that, when a patient has cardiomyopathy and they have a VUS, the main reason for updating that is basically if there are siblings or other family members that are going to benefit from testing so that they, if they're negative, they could then stop surveillance. That's the main use. I think in patients who have cardiomyopathy and they've had negative testing, it depends a little bit on the phenotype, but we will retest if we think that there's, you know, probably like a 5% increased yield, either because the panel that they had is missing a lot of genes, or there's been a new gene discovered, or maybe, you know, they've developed bad arrhythmias that aren't like particularly explained. And so now we're going to do a combined cardiomyopathy arrhythmia panel or something like that. We have been fortunate. We haven't really had a hard time with insurance in terms of approving if we need to do that, but we don't, it's usually been several years since they've had testing.
And the lab, do they, like, if a variant gets upgraded or even down, does the lab that has done testing, is there a mechanism for the lab to inform the patient? Because they probably have the most, no.
Typically not. I mean, it's been a big area of contention amongst labs. Of course, many physicians want the labs to be the ones to be responsible for it, where they would send out an updated report. At some point in time, when the EMR was, there are some now where the portals can directly receive the results from the testing lab. And in that case, the testing lab could push out an amended update if they saw it. But they will only do that if another patient comes in, gets tested, they have a different, they have a new, they've upgraded or downgraded, and then they see, okay, well, here's the 10 other patients that we've seen that have had the same variant, and if they have the ability to push that out, they might do that. They have no way of knowing whether that patient is still being followed at that healthcare institution or anything like that. So, and then the other thing is, I think the thought is that ultimately it is the physician that makes the diagnosis in terms of, yes, this makes sense, or no, I don't think that this explains it completely, or I'm not comfortable. Especially, for example, saying I'm not comfortable for a sibling using this as the sole determining factor. I don't believe it explains the whole picture that I'm seeing in this family, and the lab says, we don't have the ability to, and we're not clinicians. So, so they really do put it on the provider. So far, there hasn't been a lot of medical legal activity in this area, but it, people are very nervous about that. And it's a reason some providers don't want to order, because they don't want to be responsible for that. They would rather, and I think that's like a perfect opportunity to have a genetic counselor or a geneticist doing, because that's like what we do. So like, what else would we be seeing, especially when a patient's coming back for follow-up, if they're not syndromic or something like that, we most often will have the genetic counselor see them, but sometimes it'll just be the geneticist in clinic that day, but it's like really, what else am I doing for that patient at that visit other than, updating the pedigree and doing the variant interpretation? So that's kind of my role.
Thank you so much.
All right.
Thank you very much.
Thank you guys for your attention.
And I'll remind everybody that tomorrow Dr. Ware is giving a wonderful talk on heterotaxy genetics at 8 o'clock at Pediatric. In person, there's going to be a breakfast. Wonderful, just like that. Stephanie, let me get you your coat.
Okay.
Stay right here. I'll tell you.
Thank you all on
Thank you.
Zoom.
Have dinner.